Uh, well, welcome to today's Echo. I'm Dr. George Ford, Pediatric Endocrinology, East Tennessee State University. Today we're going to be talking about transgender-related issues. So if you have questions or things come up as we're talking, please feel free to chime in. Always a little harder, it seems like, to make it as interactive when it's over the computer, but I would like to make sure people have an opportunity to ask questions. So I'll try to pause from time to time to make that happen. I'm going to go ahead and pull this up, or just click on that, bring it up. All right, we're just trying to bring up the PowerPoint so everyone can see it.
I think you'll enjoy everything better if you just have fewer of them. This one's cracked.
Okay. So today, this talk is actually a much longer talk, so it's been somewhat truncated to be part of an echo, but I've tried to go through and find the most salient points, and also hopefully we'll touch on things that people often ask questions about. But we're going to look at kind of both ethical and medical considerations in the care of LGBT patients, and in particular, the focus will be the case of a transgender through, and kind of little things that they ask for when they come to see pediatric endocrinology. My disclosure side, neither I nor any of my family members have any financial interests or arrangements or affiliations related to transgender care. So a couple objectives. First is kind of basic terminology and understanding gender-related terminology. I'm not a legal expert, but I have reviewed the laws in Tennessee and tried to summarize what they say in regards to LGBT individuals. And then, of course, we're going to go through the case and look at the benefits and risks of hormone suppression and cross-hormone therapy in the care of transgender as adolescents. And then, somewhat in brief, but we'll go over various ethical conflicts that arise at the interface of law, parental authority, and, of course, parental autonomy. And all those seem to come to the fore in most cases. Just kind of a basic background. Obviously, LGBT represents very distinct populations. The way in which medicine has framed the LGBT community has very much created a culture of somewhat lack of trust between LGBT and medical providers. Of course, homosexuality was in the DSM until 1973. And so these kind of previous negative experiences have really created barriers to care. And especially during the 80s, HIV stigma created quite a bit of distrust. So basic terminology, so gender identity is going to refer to a person's basic sense of being a man or a boy, a woman or a girl, or another gender. So people kind of reject the traditional binary classification of gender or consider them queer. So that is quite a spectrum there. And then you have just gender expression, which is kind of characteristics in one's personality, appearance, and behavior that are culturally defined and often vary between cultures. And then you have gender role conformity, which is the extent to which an individual actually adheres to the cultural norms prescribed for people of her sex. For that one, I always just remember my friend who's married with 2 kids. His favorite thing is to bake and to sew, which would not be typical roles assigned to the male gender. So other important thing is just kind of understand how the diagnostic criteria have changed as it relates to transgender teens. Originally in the DSM-4, it was gender identity disorder. And I'm not going to read that. You can see what's on the slide there, but you can see it was somewhat long and a little bit confusing in a way, diagnosis of how that was to actually be defined. The DSM-5 redefined it simply as gender dysphoria and really simplified the definition to an incongruence between one's experienced gender and the gender to which the person has been assigned. It also kind of created a nomenclature in which you refer to the person's kind of gender at birth as their natal gender. So gender dysphoria, this is one slide that could be its own presentation, but essentially in pre-adolescent children, there's a great deal of fluidity in kind of gender expression, gender identity. In fact, 80 to 90% revert to their natal gender by the time they hit adolescence. There's quite a bit of controversy about how that pre-adolescent gender dysphoria should be handled in this talk. That goes beyond the scope of this talk. And then adolescents who, however, have persisted for greater than 2 years in affirming their transgender identity, much less likely to desist to their natal gender and rarely do. Just kind of important turning points in LGBT history to be kind of thoughtful and aware of. Again, this is really important how kind of the community interacts with the medical community. But you have the 1969 riot at the Stonewall Inn in New York City, which is considered by many to be the beginning of the sexual minority rights movement. In 1973, they did remove homosexuality from the DSM, but they did replace it with kind of a confusing term, ego-dystonic homosexuality, which was a persistent lack of heterosexual arousal, even though they wanted to initiate or maintain heterosexual relationships and related distress. However, 1975 was kind of a banner year for the APA as they began to try to eradicate stigmas around homosexuality. And then 1986 was actually the first time that DSM did not include homosexuality as a category. Other things kind of that have affected us are obviously political. So we have the Clinton era, which had the don't ask, don't tell policy. Basically, you could serve in the military as long as you didn't talk about your sexuality in any possible way. And if you look there on the right, there's kind of this is an actual pamphlet that was given to train people on how to use this policy. And if you look under that kind of section on what is credible information, it's pretty much almost anything. And it kind of brings into question the word credible. Basically, anyone could say they heard or overheard someone say something or heard that they intended to do something, and that could potentially get them discharged from the military. Barack Obama, of course, ended Don't Ask, Don't Tell in September 2011. The other major kind of cultural political landscape has been the legalization of gay marriage. It wasn't until 1990 that WHO actually no longer defined homosexuality as an illness. In 96, of course, that's why the Supreme Court created kind of a firestorm when they allowed for same-sex marriage, which was followed by the Defense of Marriage Act from Congress. 2003 changed things due to Lawrence versus Texas that struck down all sodomy laws. And then there's a very long legal history between 2003 and 2015 as it relates to the legalization or state laws trying to prevent gay marriage, but this was all overturned by Obergefell versus Hodges in 2015, which legalized gay marriage across the United States. So we've talked a lot about that. Let's kind of just get a little bit to Tennessee law. So interesting enough, Tennessee law does not prohibit discrimination based on both sexual orientation and gender identity. There are laws in place for hate crimes for sexual orientation, but that does not include gender identity. There are some exceptions. There are cities and municipalities in Knoxville and Memphis, areas of Nashville that have ordinances to protect both sexual orientation and gender identity. Tennessee Board of Regents has established a policy of non-discrimination for both sexual orientation and gender identity employment. but the University of Tennessee covers sexual orientation only. Other things to know, Tennessee is actually the only state in the United States where a law exists that was put in place in 1977 that prevents a transgender person from changing the birth certificate to the gender that they identify with. So that's kind of a unique thing to Tennessee. You can change your driver's license, although the way in doing it is a little interesting. The attending physician has to sign off that necessary medical procedures to accomplish the change in gender are complete. I'm not exactly sure what defines complete or what interventions are actually necessary to confirm that or how they would confirm that themselves. And then you can also change your name, but that would be through the court system. Just to give you a sense of general things that Tennessee law allows adolescents to obtain care for without parental consent. They can get mental health care, emergency treatment, prenatal care, STI services, etc. One thing in the state of Tennessee that requires parental consent is abortion. And then we have the capacity for minors to give informed consent. Basically here, the magical age in Tennessee, and this varies very much by state, is 16, at which point there is a mature minor exception, which allows for behavioral health treatment to be given. Basically, it's kind of presumed that a 16-year-old has maturity to consent to medical care, and it defines that to include mental health care. They can, at that point, sign for their own consent treatment services and for tests. When I look into Tennessee law to find anything that specifically relates back to transgender care, there is nothing. So it's not exactly clear how the statute would either be implemented or not implemented as it relates to transgender care. But in theory, it would protect a 16-year-old in making decisions. So why do we care so much about providing care to these LGBT youth? There's a very high risk for suicidal ideation, depression, rates of smoking, alcohol consumption, and substance abuse are higher than their heterosexual peers. They make a disproportionate number of homeless youth that are on the streets. And they also, there's other studies that show they have an elevated level of violence or victimization and harassment. Certainly it's very common as I talk to LGBT people in our clinic that bullying has been a significant issue for them. The last patient I spoke with had to switch high schools because of it. Getting kind of more closely down to kind of risky behavior, there's not a lot of great studies on transgender, but this is one from 2010. And you can kind of see that the rates here of thoughts of suicide, more than half attempted suicide, a fifth have done some form of self-mutilation, of which cutting is very common. You can see about a quarter have actually tried to use, like, over the internet, kind of black market hormone therapy. And I have had people actually who were doing that here in the community here, and then have come to me, and we've been able to actually do the right things to give them the proper doses and monitoring on those medications. Some people have alcohol use again, and drug use. You're looking at about 3 and 4. And often they're usually sexually active, and those substances are involved. So this is kind of more the meat of the talk, and where I think most people will kind of want to maybe ask some questions. But first, any questions up to this point? So, so this is Mary, a 15-year-old transgender female. So they're natal male. So they're male to female transgender. Has been referred for management of gender dysphoria. She began to experience gender dysphoria at age 11. And that has persisted to the present. She was previously treated by pediatric endocrinology with a GnRH analog. that suppressed puberty and prevented kind of natal secondary sexual characteristics to which the patient did not identify. The one thing about that treatment is it is a reversible treatment, because if you stop it, the person will enter their natal puberty. She notes that some of her friends who are only 14 have actually already been able to access cross-hormone treatment. And so she feels like she's ready to transition. So just to give kind of a basic endocrinology overview, at the top, you can see your hypothalamus. That's where you're going to get your GnRH pulses. Those pulse, it's the pulsatility of GnRH that implements puberty. Usually begins overnight in early adolescence. That's going to cause pulsatility down there below in pituitary for your FSH, LH, and then of course related production of pubertal hormones and then negative feedback to the pituitary and hypothalamus. So basically, when you give a GnRH agonist, what you're doing is you're eliminating that pulsatility. Although the initial dose is actually somewhat of a pulse, after that it basically flatlines the GnRH, which then suppresses the FSH-LH. So other kind of information about Mary. So she does regularly see a psychologist who has confirmed that she doesn't have any other comorbid psychiatric conditions. She's also signed off that she meets criteria for gender dysphoria and that has been persistent. In terms of sexual identity, she does identify as bisexual, but with no current partner. And when you ask kind of how sure she is of her gender identity, or if she doubts it somewhat, she says, no, I'm 100% sure that I'm female. And she feels like she's ready to jump into cross-hormone treatment. So that kind of brings me to guidelines from the Pediatric Endocrine Society for the implementation of cross-hormone therapy. And this is a common question, is when should I refer, when can a child do this? And it had been very kind of clear in the prior criteria that the minimum age was 16 for the initiation of cross-hormone therapy, but the most recent criteria that were put out just last year did put an exception that said earlier if compelling reasons were to do so. And those compelling reasons would be basically defined by the physician, and they're not really well defined as to what they actually are. So there is some in the community who pediatric endocrinology feel like we should be intervening earlier. There are others who disagree because of some of the irreversible effects of cross-hormone therapy. So we're going to go into that. And then in terms of reassignment surgery, of course, Mary is also asking for that at this time, in addition to the cross-hormone therapy. But the minimum age is 18 for that, and that has not changed over time in terms of criteria. And obviously that has some very permanent, non-reversible changes. I have heard, though, however, of some people in various parts of the country allowing 16 and 17-year-olds, for example, to get a mastectomy, kind of ignoring these particular guidelines. Any questions on those guidelines? So we could do a whole other slide of going the other way, but we're going to talk about Mary. So estrogen treatment in a natal male. Some of those side effects will include a redistribution of body fat in a female distribution, decreased muscle mass, libido, potentially less spontaneous erections, and possible just erectile dysfunction. Breast growth, of course, and that usually is going to occur over about 1 to 2 and sometimes 3 years. I guess one benefit is decreased male pattern hair growth. And then you are going to get decreased testicular volume, and that's going to relate to really the Sertoli cells and sperm production, and that's going to cause resultant infertility. Sperm really rely on a very high testosterone level in the testicles itself, which would be suppressed by getting exogenous estrogen. And then obviously if they've been on Lupron before, they would have no voice change. However, a lot of patients have gone through their natal puberty and then go on cross-hormone therapy, so that part they would just have to talk to the voice coach to work on that. And then you have all the psychosocial impacts, obviously, of being on treatment. In terms of other risks, these risks are, I would say, very poorly defined because the studies of transgender individuals, the cohorts are very small. Some of the studies are literally including only 20 or 30 people. So whether or not some of these risk factors are actual or just reflect a small cohort of people is unclear. One thing there seems to be consensus on, and also just makes sense physiologically, is that there is a higher risk of thromboembolic disease when you introduce a lot of estrogen into a natal male. And then you could kind of see several moderate risk factors there. I do often review with families if there are strong family histories of breast cancer, coronary artery disease, cholesterol issues, just to kind of get a sense of what their baseline risk is for those. Any questions on that slide? I agree. Okay, so kind of getting back to sex reassignment surgery, it actually needs to be completed after cross-hormone therapy, and that's in part to ensure that the person has continued to persist in their gender identity and has responded well to the changes from cross-hormone treatment. And so in this case, a natal male receiving surgery could have a gonadectomy and penectomy. Again, the consensus from the Pediatric Endocrine Society is very clear. Given how weighty and irreversible such a procedure is, they do not recommend that a child be allowed to make that decision. This brings me to another important point, and this comes up a lot. There's usually a lot of parental discontent around it, and it's not odd for one or both parents to have issues regarding treatment, and it's often split between the two parents. In this case, the father was actually very supportive of her getting the estrogen treatment. Dad feels like her psychological well-being is really being impacted, that this is really going to help her, and that it's the right thing to do. Mom, on the other hand, feels like Mary's just not mature enough. She kind of is questioning a little bit her ability to make kind of these life-changing and somewhat irreversible changes by getting treatment. Mother also kind of still uses male pronouns and believes that God has not made a mistake, and so does not want him to receive treatment. And at one point, she's also so upset that she threatens to sue if anyone tries to go forward with treatment. Again, Tennessee law would suggest the age 16 that the child can consent. In this case, Mary is a little younger than 16. In terms of kind of why do we respect parental authority, both in law and in medicine, obviously there's exceptions to this that we see, but generally parents have the child's best interest at heart. They bear the burdens, and including in this case, the financial burdens that are included with transgender care, some of which are sometimes heavy because some insurers do not consistently provide coverage for various things, such as labs that need to be completed when someone's on cross-hormone therapy. But in theory, parents' love and concern and their right to make decisions for their child hold important sway. In terms of kind of this fight between kind of mom and dad about whether or not cross-hormone therapy or the next step, surgical changes are ethically or medically warranted. There are differing views. We've kind of gone mostly over supporting views. And obviously, there's quite a bit of issues with suicidality, self-harm, other rates of violent behavior, psychological outcomes. There are good studies coming out now that show that people who persist with their gender dysphoria and receive these treatments have much lower rates of depression, suicidality, and that they often thrive. Some people have very much dissented, and you can definitely find all kinds of people that do for various reasons. I don't have enough time to go through them all, but the most common one that's cited is Paul McHugh. He was involved with a lot of gender reassignment surgeries, and basically, and when they went to look back to see if these were helpful to people, they actually found in some people a higher rate of suicidality and mental difficulties after they underwent surgery. There are other studies that contradict that finding, so there's mixed data. Basically, his argument was you can't really, you can basically masculinize or feminize a person, but you can't really change their gender. And he concluded that the surgery could potentially be promoting a mental disorder. Although his views are not currently representative of most psychologists or medical groups, there are some that agree with him. So it's not something, I think it's something that needs to be discussed politely and respectfully. And when parents have various concerns, I try to respect their beliefs and their objections, and to kind of objectively discuss kind of the benefits and risks of treatment. Any questions on that last slide, or any other questions in general? So kind of some basic conclusions. First, using a GnRH agonist, it is a reversible treatment. It will suppress puberty by getting rid of the pulsatility of GnRH. It's less controversial because it's reversible, and people kind of see it as buying time for the teen to kind of make sure this is what they want or don't want. It's kind of rare for people to go on Lupron and then change their mind and want to go through their natal puberty, but it has happened. And then obviously doing that kind of pubertal suppression certainly optimizes the results once they start cross-hormone therapy. And so overall results of psychological well-being and a longer-term mental health seem to be improved by this earlier intervention. I will say in the South, it's kind of rare for people to get to us when they're younger. Although that's changed a little bit as people become aware that there are services in our region. But overall, it's more common that people come to us having already completed natal puberty. Cross-hormone therapy certainly has the benefits of allowing the transgender youth to take on the physical characteristics that they identify with. It certainly appears to be helpful for their psychological well-being. I've certainly had many patients come in after a year or two of treatment, and it's like their lives are transformed. The depression is gone, they're happy, they're well-adjusted, they feel like they're in a body that they identify with. However, as noted, there are medical risks, there are ethical concerns, there may be religious concerns. Transgender care tends to cross every possible paradigm in terms of interacting with various beliefs and or assumptions. And so it's just really important to have a very honest, open discussion with patients and be respectful of those who may have dissenting opinions. Mary does want treatment. She's 15. The guidelines would basically kind of say it would be left to physician judgment if the physician felt there was compelling reasons to move forward. Just kind of looking across the country, I would say pediatric endocrinologists vary. And some people are very big on making sure decision-making capacity and other things are very clearly in place, that the gender dysphoria is truly persistent, and trying to be very careful not to treat someone who might persist. Others seem to be feel much more strongly about starting even as early as 14. So that varies by region. And then we kind of talked about gender reassignment surgery, but it really doesn't really enter the pediatric endocrinology realm. And I'm very strict with the guidelines set forth by the PES in this regard. I don't refer for any forms of gender reassignment surgery. And then, as noted before, there's more conflicting data from various people as to the actual efficacy of providing that treatment. So one question I get quite a bit, and if you have questions about this, feel free to ask. But when do you make a referral? And I would say as soon as you kind of figure out that someone's probably experiencing gender dysphoria, it would be good for them to establish care. Even if they haven't yet entered puberty, it's nice for us to be able to kind of intervene. Usually, GnRH agonist is started just as someone's entering 10 or 2 stage, breast female or pubic hair for a male. It's usually done that way just to ensure they aren't going to desist to their natal gender as those hormones start, because there's good evidence that if they haven't desisted, that they'll persist. But you know, so this is one of those things where as a pediatric endocrinologist, I must work with the team, the PCP, the mental health provider. Mental health provider, actually, in this case, I can't really move forward without their assistance. So a person needs to be getting regular therapy. They need to be looking to see if the gender dysphoria is persisting over time. We usually like to see that persisting for at least 2 years. And also kind of looking for any comorbid mental health conditions, depression, anxiety, self-harming behavior, suicidality, all these kinds of things that we try to address, and make sure that there's no other conflicting kind of abuse or something that could be in play. And then the other thing would be, so really I have to get a letter from the mental health professional that says those things have happened, gender dysphoria is persistent, they don't have any currently untreated concerning comorbid mental health conditions, and that in their assessment that the child has the decision-making capacity to give consent for these treatments, which again includes some irreversible side effects. So it's a fairly weighty decision. And I have a very honest and open conversation where I go through all of these things with transgender teens, and I often repeat them to try to make sure they really have a good sense of what's going on. If I get the sense that they really aren't taking it seriously or understanding, I often will have them wait and talk with their mental health professional and discuss those changes to make sure they really understand them. In terms of what we like from the PCP, certainly anything regarding the history of gender dysphoria, when it was first noted, whether it's been persistent, any prior treatments with another group or endocrinologist, such as GnRH therapy to suppress puberty, who their current therapist is, any relevant mental health history, excuse me, is all very helpful. I've been talking too much. Need more questions. So these things are all really critical because I can't really move forward with treatment until all of them are very well established. And I feel like both the parents and the child are fully informed. So these are kind of reflections. Oh, this is from an old slide actually, but it should say she. But does she have the decision-making capacity to make these decisions? That's an important thing. Should her autonomy be respected? And then of course you have the parental issues. In terms of trying to reconcile those, I try to make sure that all parents have essentially assented to treatment, not necessarily that they're endorsing or excited or agree with it, from a cultural or religious perspective sometimes, but that they've come to a conclusion that they respect the adolescent's decision to make a decision, and that they recognize the potential benefits for their overall mental health and avoiding some of these other issues with suicidality. It's often, once I've talked to a parent about some of these issues, and sometimes as the patient is actually reflecting on them and sharing some of the struggles they've had, it's often the parent begins to realize that this is not a kind of small matter, and that it's something that needs to be addressed, even if they have some misgivings about potential treatments. And then, of course, law, trying to understand both state law, Tennessee law really doesn't have a lot of protections for the LGBT community. There are some federal laws, though, that kind of supersede them, that help. So another thing would be reflecting on kind of what laws should be put in place for LGBT and transgender youth. Kind of what are we doing for them? Any questions or thoughts as we look at the reflection slide? What's that? You have to take yourself off mute to ask a question, in case you wanted to ask a question. Yeah. Such a quiet group. I usually get more questions than this. Okay. So this is the part where I was hoping to have a discussion. So any thoughts or questions that have come up from what I've talked about so far?
I have a question.
Sure.
So this is Will Dodd over in pediatrics. I have several patients, adolescent patients, who identify as transgender, but have significant familial disagreement, you know, on the best course forward. Are there any like local resources in terms of counseling or support that are available to these patients?
Yeah, I mean, we have identified certain counselors or mental health professionals in the community who have some experience and expertise in helping children with gender dysphoria. And so oftentimes when well, I don't know if we really have a great mechanism of sharing that with the whole community, but when people come to see us and establish care, even if they're not even ready yet for any of the treatments we provide, we often will refer them or get them in contact with some of those providers. We probably need to have a better mechanism of sharing some of that information with PCPs.
Okay, thanks.
Any other questions? Another question.
George, this is Dave Wood.
Hi.
Thank you so much for a wonderful talk so far. You know, I've gone into the Tennessee law too, and the mature minor law is very unclear to me when you can invoke it and say, well, this person has the right to make their own decision, medical decisions. In Tennessee, there's definite exceptions for contraception and sexually transmitted infection treatment, but it's really fuzzy after that. And I think if we do decide that someone deserves to make a decision on their own, obviously you're working with the parents and trying to reconcile the differences of opinion, but I feel I would need to talk with, counsel, ETSU counsel, before I went forward with something like that, because I do think it's unclear, and I would hate to open us up to a lawsuit, especially since the mom here in this case has threatened one. So that's it's really difficult. It does seem like the Lupron, or the suppression of what the message to me is, we should really be talking about this with folks if there are obvious gender issues, before they hit puberty, or even early in puberty, so that the kind of temporizing treatment could be entertained while people work through these issues.
Yeah, no, absolutely. In fact, I agree with everything you said, Dr. Wood. As I went through this, I kind of felt like things became more ambiguous because there really aren't a lot of very clear laws in place. Tennessee in general doesn't even have clear laws that protect LGBT individuals, except for hate crimes for those related to sexual identity. I've always sought parental consent before moving forward with treatment in these patients. In part, that's because we feel like there is not a clear legal standing for the adolescent to make the decision. And so basically we try to make sure both parents are at least willing to assent to treatment. The one thing we have run into with that is sometimes people are deceptive. So might be a divorced family where dad's not really involved per se and lives in another state, and both the child and parent say that parent is completely on board and 100% supportive, only for us to find out a couple months later when we get a random call from Arizona that that's not the case. I've also had a college student who was 17 at the time, so not yet 18, who was treating herself with estrogen that she was buying from Canada, totally using the wrong dosing, very dangerous what she was doing. She had indicated, she came by herself to the appointment, but indicated that her parents had been very supportive of her transition. So we got her on legal estrogen and proper management and lab follow-up on treatment. But we did find out shortly thereafter that the dad in that situation was totally against treatment. And he came to our clinic rather upset. So I spoke to him for about an hour and had a very frank and honest, open conversation, mostly listening. But by the time we were done, I think he really understood why this was going to be the better way than kind of her taking these black market estrogens or other hormone therapies that she was trying and doing it the way we were doing it. One thing for him that was hard and very acceptably hard was that in this particular instance, the insurance wasn't covering a lot of the costs related to treatment, including like lab follow-up for being on estrogen. And so the financial burden fell to this parent, despite their strong, in this case, very religious objections to the treatment.
Well, thanks. Thanks for the discussion.
Any other kind of thoughts or things people wanted to ask about? All right. So just want to remind you, we have another session coming up. It's going to be on the thyroid, which I would assume most people run thyroid tests fairly frequently, since it can impact multiple organ systems and seems to come up quite a bit. So please come for that. It's on February 14th. So February 14th, so mark your calendars for that. Should be a really great opportunity to kind of get a good sense of when to refer with your thyroid labs, understanding kind of some of the basics of interpreting thyroid labs. And I think it'll be a very pertinent discussion. Thank you for coming.
Thanks, George.
All right. Yeah, we'll end there. Thank you, everyone.